Welcome, welcome. We are honored.
Thank you.
We are truly honored to have you. Thank you so much for joining us.
I am equally as honored. I want to thank Dr. Julia, Dr. Grace. You know, it's such a small world. We met in London when we can travel, when I could travel, you know, before the pandemic. Just the world is so small that we're now connected again. And to Dr. Grace, we met in the Leadership Institute of Black Nurses. Thank you so much for inviting me here today. I want to just congratulate you all for being nurses. We're all alive and grateful by the grace of God for the person that mentioned that during the opening. So thank you so much for having me. Today's talk, I hope you enjoy it. The title is The Growing Role of Public Health, COVID-19 Beyond and Understanding and Addressing Social Determinants of Health. I am Natalia Cineas, Senior Vice President, Chief Nurse Executive at New York City Health and Hospitals. And again, congratulations on putting together an amazing conference this year. So I serve as the clinical lead for 9,600 nurses. And I saw someone on the chat write that their Chi-Chi is from Jacoby in the Bronx. Within our system, we have 9,600 nurses, huge. I also oversee 970 social workers and approximately 400 respiratory therapists. It's an amazing organization. I'm going to talk about that today. And I'm going to get into COVID before and after to really align with the theme of this amazing conference. I'm also the co-chair of the Equity and Access Council. And I'll talk about why we started the Equity and Access Council and the work that we have to do as a profession today. The learning objectives for this conference and this talk, because there are CEUs, is number one, to explain how social determinants of health contribute to disease, including COVID-19, right? And chronic illnesses, infections, maternal mortality, morbidity, situational emergencies and accidents, and domestic violence. To also give a broad overview about the framework of social determinants of health. So we're going to talk about the contributing factors to social determinants of health: neighborhood and built environment, social and community context, economic stability, education, and healthcare. We're also going to illuminate the important role that public health nurses play, public health systems play, and how that really affects Blacks. Right? And we're going to identify and address how these social determinants of health are impacting our communities. We're also going to talk about how do we promote health and wellness by taking on some of these social determinants of health. And last but not least, we will examine how the social determinants of health have a significant impact on evidence-based professional practice and overall patient care within the public health systems and systems in general. So just to tell you a little bit about New York City Health and Hospitals, where I have the honor and the privilege of serving as Senior Vice President, Chief Nurse Executive. So we are in all boroughs of New York City. I mentioned Jacoby, we're in all boroughs. We have 11 acute care hospitals. So if the president were to get injured here in New York, he would go to Bellevue Hospital, one of our hospitals. We have 5 long-term care facilities. So that's 5 nursing homes. We have over 59 clinics. We are the largest federally qualified health center in the country. We have nurses in correctional health. That means we have all nurses in New York City jails. We have nurses in the community. So nurses who are assigned to go into patient homes. And you can only imagine how hard that was during the pandemic. We serve, as you've heard, 1.4 million New Yorkers, but we also serve 5 million New Yorkers when you take into account ambulatory care. And we are the largest provider of the uninsured. That means a lot of our patients do not have insurance, and a lot of our patients have Medicaid, low income, and they're undocumented. We are the largest provider for undocumented immigrants and the mentally ill here in New York City. And we also care for patients in over 180 languages. And so just an amazing system. Our goal is to make sure that the care we're providing to all New Yorkers are integrated. And our values is integrity, compassion, accountability, respect, and excellence. And my goal as a chief nurse executive has been to establish excellence across our system. So during the pandemic, it was interesting, right? For all of us who have gone through this, we saw what was happening in parallel with the pandemic. We saw what was happening among Blacks across the country. And so our mission is very unique, and that is to ensure that we care for patients who are unable to pay and to make sure they get comprehensive health services, to ensure that we're caring for them with respect and dignity and making sure that their physical, mental, and social well-being are upheld. And so during the pandemic, when we saw social injustice and social unrest across the country, our staff were adamant to do something. And so in these photos, you see white coats for Black lives, right? And that's what makes our system unique, that we support our staff regardless of, how individuals feel, but how they feel. And so the Black Lives Matter movement was supported here at Health and Hospitals. And I think that's important because when I talk about health disparities today, when I talk about social determinants of health, it all ties together in terms of minorities and Blacks and what that means to COVID-19, health disparities, and social determinants of health. So this is a quote that I found that I wanted to really put into this presentation. Nurses speak for those who may not be able to speak for themselves, right? And so my role as a chief nurse executive is to talk and advocate for individuals, for patients who are undocumented, who can't speak the language, who might be scared to come into the hospital, and to advocate for them. So what we're doing at New York City Health and Hospitals is making sure that we're touching upon every aspect of the Future of Nursing report, every aspect, to make sure that nurses in all settings understand social determinants of health. So if they're in the inpatient setting, they know what's going to happen to their patients when they're discharged and how those social determinants might make their lives just worse, might make them readmitted. And so we're going to talk about those social determinants of health today. So New York City Health and Hospitals, I talked about that we are 9,600 strong. This is a photo of our nurses at Harlem Hospital when the pandemic started. And they sent photos around with hearts because they were committed and they were passionate about what they're doing, just like we are all passionate today at this conference to make a difference. And so it's vitally important that every nurse tells their story to impart lessons on best practices. So let me share my story. While running the largest public health system in the United States during the pandemic, I got a call from one of the physicians. And the physician told me, Natalia, you can't leave your house. We just got a call from Italy and it's going to get bad. This was, I would say, in February of 2020. And he said, I need you to be safe because I am in charge of staffing for the entire system. And he said, if you go out and you get sick, the whole system's going to be impacted. And so from that moment on, I did not go out. I ended up working 19-hour days to deploy staff, which we'll talk about today. But during the pandemic, not only was it challenging for me as an individual personally, it was professionally as well. It was difficult. So we're going to talk about what I did professionally today, but I want to tell you on a personal level, I lost my uncle due to COVID-19. And so when I do talks like this from a global perspective, I can't help but share the fact that my uncle was in Haiti. My parents are from Haiti, and he went back. He had had cardiac surgery, he was diabetic, and he was in Haiti. And he contracted COVID-19 and he died. And I was devastated. And this was in the beginning of the pandemic. And so when I think about the lives that we lost during the pandemic, and we'll talk about that today, I think about my own personal loss. And so this is a talk that hits home for me because I did suffer loss during the pandemic while executing a lot of strategy to make sure that all of our New Yorkers were safe. And so we know that nurses are the heart of our mission to ensure that New Yorkers receive compassionate care, right? And so we have to really be passionate and compassionate at the same time. And through education, through training, through advocacy, we have to ensure that the basic needs of humans are met, right? It goes back to Maslow's hierarchy, making sure that patients are fed, making sure that they have everything they need to survive. And so we're going to talk about, again, how if individuals do not have those resources, how they can be impacted. Nurses serve as patient advocates. We know this, to ensure that quality care is provided. And as I mentioned before, New York City Health and Hospitals, because our patients don't have insurance, because they're undocumented, because they speak in over 180 languages, the care that we provide is that much more complex. That means our patients are coming in later during their care, usually end-stage cancer, usually when they're having a cardiac arrest because they don't have primary care. And so we're doing a lot to prevent health disparities. And we'll talk about the correlation between health disparities and COVID-19. Public health is challenging, and even the private sector is challenging because I've worked in the private sector as well. But nursing is challenging, and we know that, right? So this is a photo I wanted to share with all of you because this was the moment for me that everything changed here in New York. The White House had sent out the comfort, and we were responsible for the comfort. So not only was our team responsible for all of those areas I mentioned in the beginning, but we are responsible for a lot of other centers, Billie Jean King's tennis court, staff in, Central Park, test and trace, a lot of different other areas, including the comfort. So I remember when the comfort was coming and I was thinking to myself, this doesn't seem safe. I feel like the ship's going to get COVID. And within hours, of course, it did. But this to me illustrates what was coming and what happened right after. So immediately after the comfort arrived, and we got our first case here, we had to quickly change the way we were onboarding nurses. So this is a photo of myself and my senior director of nursing education, really working from a virtual capacity. We had set up virtual centers. At this time, I was still in the office, but very quickly, I could not even be at the office because some members of my team got ill. And so we did what you call flipped classroom. So for the academics, in the room, you understand this, but we had to really develop educational program content through remote learning. And this was new for a lot of our educators. We had to ensure that all of our content and materials were quickly created for online training, which was difficult and complicated because nursing has to really ensure that nursing informatics is really integrated with nursing practice, making sure that everything is automated. So if a nurse was coming into the hotel to come and help us, how do we train them if we can't speak to them, if we can't be in the same room? We had to quickly create online curricula to make sure that we're able to communicate with frontline staff. So here we are communicating to staff virtually. We had to quickly create COVID-19 educational material. Within 3 weeks, 7,000 nurses completed this training about COVID-19. Constant training. Even now, we just created the content for the booster vaccine here in New York City for pediatrics. Constant change. And so we also had to do a lot of training around medical records, 5 times a day, night shift training to make sure that nurses could do EMR training from their phone, right? In their hotel room. So they're not around each other because even the nurses that were coming to help us, we had to make sure they were not sick. When it comes to disaster management, we were so fortunate that we had the assistance of the Department of Defense. And that's very humbling, right? To train the Army, the Navy, the Air Force nurses to make sure that they understood what to do. And that was humbling. We also realized that every nurse was a nurse. It didn't matter where you were. Was it in academia, whether you work in the Department of Defense? If you're a nurse, we needed you. And so we had school nurses come in to all of our hospitals to work in an ancillary staff capacity, to do one-to-ones, to do activities of daily living, to make sure that our patients were remaining alive because nurses were getting ill. We've lost nurses, right? And so we had to really get all the help we can get. So I and my team had to deploy 5,000 nurses for wave 1. So just think about that. 9,600 nurses in the system. We still needed 5,000 more nurses. That's how hard we were hit. Wave 2, we had 1,249 nurses come in to help us. And then we had to partner in the academic setting to get 1,000 nurse vaccinators, students who could not complete their clinicals to come in and help us from a vaccine perspective. We have since then triumphed. We have had over 50,000 patients discharged safely. We persevered, we remained resilient, but now going back to the theme of today's conference, what is sustainable healthcare? What are we going to do now from the lessons that we learned? How are we going to move past the pandemic and to really think, why did so many minorities perish during the pandemic? And what will we do to prevent that? And that is how social determinants of health comes into play. So since the pandemic, we have safely tested and traced up to 2 million New Yorkers to make sure they are COVID negative. We also established hotels in New York City where staff and individuals were able to isolate from their families and from their colleagues. And so we ran what we call isolation hotels, beautiful hotels where individuals can go and isolate for free. And we've had 25,000 safe discharges from these isolation hotels. Nevertheless, of us being resilient and we've persevered, the pandemic, as we all know, has caused more than 250 million cases globally, more than 46 million cases in the US, and more than 5 million deaths globally, and more than 766,000 deaths in the US. And I can't imagine the countries globally where the numbers were not counted, right? And this is just a depiction of that. How many cases, right? Over 200 million. How many deaths? Over 5 million deaths. Still rising. This is as of November 1. Although we have seen a reduction of admissions, I will say, here in New York. So let me give the audience a poll. Again, thank you for joining me, and I hope you enjoy this presentation. How many healthcare professionals do you think contracted COVID-19? Feel free to put it in the chat or just think about it. When we think about the terrible toll that COVID-19 has plagued all of our countries, how many healthcare professionals here in the US have contracted COVID-19 or globally? Just think about that to yourself. I'll give you guys a couple more seconds. Okay, well, when we take a look at the statistics, 666,707 healthcare personnel cases. I'll never forget the first call that I received when we lost a nurse. And that nurse, there were actually a few across the system. We lost a little bit over 20 nurses because a lot of our staff live in the communities of which they serve, right? And that was really scary to get that call. That's another question for the audience. When we think about the terrible toll, how many healthcare professionals have perished due to COVID-19? If you could put that in the chat or think about it, I'll give you a few seconds to think about how many have perished. Approximately, according to the CDC, and this is in October, we've had over 2,229 healthcare personnel deaths. And again, that is what's recorded, right? Very scary. To me, one death is too many. When we look at deaths by occupation, we see that nurses, according to the Kaiser Health News, is the highest deaths by occupation, right? And so the nursing profession, all of us need to really start doing research to think about and to combat the causes, the root causes of COVID-19, and it's ever changing. But we know, again, with statistics, in terms of social determinants of health, what it means. And that's why we have to do so much more. And that's why health equity is so important. That's why the Future of Nursing report is so important. So you see nurses here, again, at 32%. And that's by race and ethnicity within the occupation is 36% white in the context of nursing. But we know that there are more Caucasian nurses than minorities. So the ongoing COVID-19 crisis has brought health disparities among our patient population into sharp relief, right? And communities of color have been hit the hardest. According to the CDC, the share of African Americans among all people of the COVID-19 virus is almost twice as high as the population share. When we take a look at Africa, right? So in presenting to you all, I thought about this. You know, I've done research in Uganda. My brother-in-law is from Ghana. I've met, someone in charge, a CNO in charge of women's health in Ghana, and all of the amazing different Nigerian nurses that are here today. Let's think about Africa, right? We know that the median age in the sub-Saharan Africa is 18. The median age on other continents range from 32 to 42.5. And we know that age is a significant risk factor, right, for 65 and older. And we know that mostly elderly people in sub-Saharan Africa do not live in long-term care facilities, which long-term care facilities actually pose a very high risk for COVID-19. right? And so the fact that individuals live with their families was actually beneficial versus long-term care facilities, because we're still tabulating that data here in New York State. And we know that prior exposure to local circulating coronavirus results in a lower chance of death and disease severity. And we know that there's still insufficient data collection, which may mean undercounting of causes and deaths, which I've highlighted. We know that when we take a look at the rapid response of African governments, of health organizations, through the establishment of the Africa Task Force for Novel Coronavirus, screening, suspension of flights, closure of borders in 40 African nations, new programs to promote the sharing of COVID-19 information across sub-Saharan Africa, was instrumental. The stringent lockdowns that have taken a serious economic and societal toll. And the lockdowns really resulted, we know, in food insecurity. Although it was a good thing, it had negative results as well. High rates of teenage pregnancy, increased gender-based violence. We heard about that during the opening, and disruptions in treatment, right? When it comes to malaria, TB, and HIV. And we know that with variants, countries such as Africa and other countries can be more susceptible. I was just having dinner with my friend from Iceland. She told me, although Iceland's population is significantly less, they did such great contact tracing that they were tracking everyone at parties and calling them and quarantining them. And they did a phenomenal job really stopping COVID-19 in Iceland. And we know that in the African countries for which data is available, 1/3 of workers stopped working during the pandemic. And the remaining 2/3 of workers who managed to keep their jobs saw their income decrease between 11.5 and 15.6%. That's significant, right? And this is all data from the World Health Organization. Of the 15 countries, the percentage of people who lost their jobs was the highest in Kenya. And across the country, the pandemic has left more than 39 billion people in extreme poverty. 34.4, meaning that they must live on less than $1.90 a day. I just did a talk yesterday at a conference, and they were talking about the impact of the pandemic on the workforce, right? There are 800,000 jobs in nursing that are needed, and 200,000 are being filled. And that's actually healthcare in general. But if you could think about the fact that nurses are leaving, they're retiring, they're traveling, it's challenging as well. When we take a look at COVID cases by continent, we see there's a significant high number of Asia cases, Europe cases as well, right? When we take a look at from a global perspective, going back to the theme of today's conference, when we take a look at deaths by continent, again, significantly high Asia deaths and Europe deaths compared to other countries. And, when we take a look at the global scope, very similar to what I just shared, again, significant number in Asia and Europe, right? And then followed by North America. So we'll talk about the impact there. And then when you do a breakdown by the rates by country, we see the top 10 countries affected by the COVID cases. So again, within Africa, we see these different aspects of the population with COVID-19, which also correlates with the same location for deaths. In North America, we see United States, Mexico, Canada, Cuba, Guatemala, Costa Rica, Panama, Dominican Republic, Honduras, El Salvador, again, aligning when we take a look at the same deaths, same areas, right? And so again, that makes sense, the correlation between cases and deaths, but these are the areas that we should do a deep dive in across the world, globally, to find out why, right? What was happening. And so in New York City, when we look at the statistics here in New York City, from the onset, we saw that Blacks and Hispanics accounted for 56% of all documented COVID-19 cases. Blacks and Hispanics also represented 66% of all hospitalizations. Sadly, Blacks and Hispanics represented 64% of deaths. I will never forget when I visited one of our hospitals in Queens. I went into Elmhurst, and this was right when the pandemic started. And Elmhurst was actually on the news here in New York. And everyone was coming in, and it was a scene from a movie. It was so scary. And, when we thought about it, when we think about the population of the Hispanics in Queens, a lot of them live in close quarters. They live together. And so a lot of them got ill and perished, unfortunately. This is a graph that depicts exactly what I just said, right? Significant number of cases within the Hispanic and Black African-American population here in New York City. Hospitalizations, same thing, 34% Hispanic, 32% Black. Deaths, 33% Hispanic, 31% Black, as of November 1st here, according to the CDC and New York City data. So when we take a look at poverty and the correlation, we see that lower income people have been disproportionately affected by COVID-19. 77% of all cases in New York are classified as medium high or very high poverty. 85% of all New York City hospitalizations are all in neighborhoods classified as medium high or very high poverty. 85% of all deaths are in neighborhoods classified as medium high or very high poverty. Scary. This is a graph that depicts the same thing, the number of cases, the number of hospitalizations, and the number of deaths, right? You see the very high poverty graph is higher. That's the correlation. So the fact that these harsh figures are not just limited to New York City, right? COVID-19 has ravaged communities of color across the United States and globally. And according to the CDC, African Americans and other communities of color are suffering because they have worse underlying health conditions. And these health conditions are the result of the fact that they're more exposed to health hazards. So we heard about in the opening, what can we do? We can make a difference in these health hazards, which we'll talk about today. The CDC also points out that these health disparities are not just a reflection of behavioral differences, but they're a result of the policies that harm Black communities. That is why I tell our nurses in our system, regardless of where you work, and we heard this morning, that you have to make an impact. If you're at the bedside, you have to still make an impact on your community. You have to make an impact on policies. You have to get involved in your community boards, and you have to get involved on your board so that you understand the policies that are regulating the food in your areas, the air, and the neighborhoods. And we will talk about that in a moment. So we know that Black people are forced to contend with the disproportionately high death rates for chronic health conditions, heart disease, stroke, and cancers. Black women die from pregnancy and childbirth at 3 to 4 times higher the rate of white women. Black children are twice as more likely to have asthma as white children. We know that diabetes is 60% more common in Blacks than whites, and Blacks are 2.5 times more likely to have limb amputation, 5.6 times more likely to suffer from kidney disease, 3 times more likely in general to have asthma more than whites, deaths from lung scarring, sarcoidosis, 16 times more common in Blacks. Lower tobacco exposure. Men are 50% more likely than white men to get lung cancer. Strokes kill 4 times more ages between 35 to 54 Black Americans than white Americans. And Blacks have nearly twice the first time as strokes of whites. Blacks develop more high blood pressure earlier in life, right? Nearly 42% of Black men and more than 45% of Black women aged 20 or older will have high blood pressure. And when we look at cancer, 40% higher cancer death rate in white men, and African women have 20% higher cancer death rate than white women. 1 in 9 chance of Black women getting breast cancer compared to 1 in 8. You might not think that's a lot, but when we look at the fact of who's dying from the disease, well, Blacks have a probability of 1 in 31, where whites have a probability of 1 in 37, right? And research shows that Black women are more likely than other races to die from cervical cancer, right? With 10.1 deaths per 100,000 women. But the interesting part, and it's not interesting, it's actually pretty scary. Given the societal and healthcare crisis is sweeping the globe, it is important to consider the impact of systemic racism and health disparities on public health and advocacy efforts. And I will tell you, when I first even started using the word, I had to say, wow, how are people going to feel about me talking about it? But the truth is, it exists and it's real, and we have to do something about it. And that's why I'm on the board of the American Heart Association. I'm on so many boards that you heard within my bio, because we have to, work and advocate for different benefits. So whether it's making sure that Blacks get more food stamps here in New York is something that I advocate for, and I speak to different people, different congressmen, different public health officials to make sure that those who are poor can survive and get what they need. And again, all of this is just supported by the World Health Organization. And, at the end of the day, there have been numerous analyses. I shared with you the statistics that really illustrate that these conditions may be responsible for 70 to 80% of all health outcomes, making social determinants of health vitally important to improving the community. So when I talk about social determinants of health, it's a topic that I find that we need to educate more in the academic setting. We have to start from school so that when nurses graduate and they take their jobs, regardless of what setting, they understand what social determinants are. They understand that we're talking about education and access and quality, healthcare access and quality, economic stability, social and community context, and neighborhood and built environment. And we have to finally integrate academics and what's happening in practice. So they get their first job, individuals. We start learning, we go over the assessment, we're going over medications, that we're focused on document and patients leave. But our goal at New York City Health and Hospitals is to ensure that every nurse caring for every patient is thinking, what's going to happen to my patient when they're discharged? Who's going to go to CVS? Who's going to go to the pharmacy to get their medications? If my patient has glaucoma and they can't see, how are they going to use a glucometer? These are the things that we're starting to teach our nurses to think critically at a higher level, not just focusing on assessments and medications, but to think about social determinants of health at the bedside, to make sure that every nurse leader is thinking about what will happen to my patient in their social settings. Every nurse must do this. Every nurse must do this for their patients. Every nurse should do this for their family members. It's this critically important for us to make a difference on health disparities. So I'm going to talk about neighborhood and built environment. I'm going to talk about social and community context. I'm going to talk about economic stability. I'm going to talk about education, health, and healthcare. So neighborhood and built environment, right? We know this is challenging, whether you're in Africa, whether you're in New York, and regardless, the fact that there are policies created to sometimes be a barrier to care. And so we have to start making sure that every nurse is thinking about the water, the soil, the air quality, parks, transportation access to their patients, right? Whether there are vermin infestations of where their patients live. I did home nursing for a few years. I would go into patients' homes. The rodents, while I'm trying to do a central line dressing for cancer treatment, was so scary, right? What are we doing to ensure that, we're advocating for our patients with social services, care management, right? Making sure that care management is not just an aspect of nursing, that the frontline nurse don't understand what care managers do. We are all one. Making sure crime and violence, that we're talking about it. Right now, crime is up in New York since the pandemic. We are seeing more gunshot wounds. And I'm sure Chi-Chi from Jacoby can attest to this, the violence that we're seeing post-pandemic. And it's really an endemic because, COVID's not going away. We're going to have to just manage it, right? Access to food, something that I'm extremely passionate about, that I really ensure that patients have access to food, and individuals and the citizens of New York have available groceries, and doing advocacy work around this. So the topic of neighborhood and built environment, we see this long list right here, long list. I couldn't even shorten it. What you will notice as I go through these slides, because I'm not going to read everything, look at this. These negative health outcomes that result from neighborhood and built environment, guess what? They show up, all of these, for every bucket of social determinants of health, for all 5. Because social determinants does have a correlation with negative health outcomes, right? Whether it's cardiovascular disease, respiratory, high blood pressure, cancer, everything that I discussed, right? And so we have to make a difference. When we look at social and community contexts, discrimination, right? Racism, incarceration. I talked about, we have nurses that do a remarkable job in our New York City jails, but incarceration, civic participation, the psychosocial impact, community health, right? Guess what? Same negative health outcomes, right? Mental, behavioral disorders, drug, alcohol abuse, suicide, infectious diseases, STDs, tuberculosis, hepatitis C, cervical cancer, social isolation, depression, anxiety, and distrust, which we see the impact of distrust with vaccines in the communities, right? Economic stability, 3rd bucket, poverty, quality housing, employment issues, right? The minimum living wage, food insecurities, hunger, housing instabilities, homelessness. Again, guess what? The same negative health outcomes in addition to more, right? Lead poisoning and just other aspects such as poor oral health that we know can lead to cardiovascular disease. So again, same negative health outcomes with economic stability. Education, what happens if someone is not educated? We know the impact of language and literacy. Right now, what we're doing is ensuring that our patients have the ability to access their care in the language of which they speak. So I mentioned we care for patients in 180 languages. Guess what? Are we using translator and interpreter services across our systems in the US, right? What do we do? Early childhood education and development, proper nutrition, exercise, stress, high school graduation, right? That role it plays in poverty and joblessness and future success. And enrollment in higher education. We know teenage dropout, teenage pregnancy. Again, the impact of education and access to quality, same things. In addition to hepatitis, shorter life expectancy, poorer self-reported health because of the inability. And one thing that I want to implore all of our nurses on this call to remember is the impact. Be very careful of the impact technology plays. You will go to conferences where everyone will say technology, technology, technology. Guess what? Technology can be a detriment to the healthcare of immigrants and individuals who are elderly. I personally have to go to every appointment with my mother because she's afraid to use the iPad at check-in. These are things that people are thinking about as we're moving towards the future. Who's caring for our elderly, right? Who's advocating for them? Again, be an advocate for your relatives, be an advocate for your friends, your colleagues, and be an advocate for your patients. And technology is not always the solution without a navigator, without someone to help our people. And when we think about health and healthcare, right, our other bucket, again, everything from transportation, the lack of access to transportation. I can't tell you what I have to do to get my father care in terms of getting him an Uber to drop him off at his appointments, et cetera. Things that doctors don't think about, right? And that's why nurses are so important. That's why nurses, again, we are at the bedside. We can connect with the patient and ask them those important questions. We have to be sensitive to the diversity of our patients to ensure that we're giving them what they need. And again, the racial disparities cases, right, within COVID-19. And I talked about the racial disparities, right, being sensitive to that in essential workers and vaccine hesitancy. I'm proud to say that our system is at the 96% vaccine rate. And nurses are over 90%, but we've still got work to do because of the history of mistrust. And again, when we look at healthcare and access equality, same issues plus more, right? The issue with following provider instructions, the issues with following medication instructions. I mean, we have to make a difference. You know, one thing to go to a conference and to hear statistics. The other thing is for us to say, what do I do? What can I do with one person, whether it's a family member, whether it's a friend, to advocate for them, to say, this is what they need, to say we need something, to speak up and to have those critical conversations at nurses with your providers and other members of the healthcare team to advocate for our patients. So the social determinants of health, I went over the 5 buckets, right? When we look at maternal health, which we've heard today, maternal mortality is unacceptably high, unacceptably high. About 295,000 women died during and following pregnancy and childbirth in 2017, according to the World Health Organization. In every day in 2017, approximately 810 women died from preventable causes related to pregnancy and childbirth. 94% of maternal deaths occur in low and lower middle income countries. And most could have been prevented, right? When we look at sub-Saharan Africa and Southern Asia, accounted for approximately 86% of the estimated global maternal deaths in 2017. Sub-Saharan Africa alone accounted for roughly 2/3, 196,000 maternal deaths, while Southern Asia accounted for nearly 1/5, about 58,000. Again, all World Health Organization. And so we know that this reflects the inequalities of access to health services globally, right? And there are a lot of us making a difference, but we all have to work together to make a difference. And even if one person becomes interested in global health, or one person becomes an advocate where they work, or one person becomes an advocate in the lives of their relative, we're going to make a larger, more significant impact. Okay. And so we know that the risk for maternal mortality is highest for adolescent girls under 15 years and old because of the complications. And the fact that, there are women who are in many more pregnancies in less developed countries, right? And that leads to the risk of death is higher. But we see this also in New York, right? We see this. And so there's work that we have to do. Many of us have seen this chart. It's data for Switzerland, right, and the UK. I know someone's here from the UK. I saw that in the chat. I hope you're enjoying this talk. But we know that the US ranks among the worst of wealthy nations. And I've seen this slide many, many times. And that's why, as the chief nurse executive now, I'm making sure that we just establish what we call a health equity forum to partner with the academic setting to make sure the schools are teaching our nurses about this, but not just the graph. What does this mean to the Black patient who is pregnant, who comes in through the doors? What are we doing about her care, right? Making sure that we're advocating, making sure that we're not just dismissing the care that we provide. And the overall rate of severe maternal morbidity has increased almost 200% over the years, right? Again, unacceptable. And we know that pregnancy-related mortality is the highest among Blacks at 41.7 deaths. I mean, we have to do something as the largest profession in healthcare, nursing, right? We have to partner with our colleagues that may not be Black or brown to work on this. And that's why I'm so proud of all of the organizations that I'm in are really talking about finally inequities, but we can't stop the conversation. So women die because of complications. And again, these complications are severe bleeding, infections, high blood pressure during pregnancy, complications from delivery, and unsafe abortions. And they also die because sometimes, again, racism, right? We need to make sure that the people who are caring for people who look like us, right, are treating us with the best evidence and the best care. And that means if we're in the room and there is a surgeon or a doctor that may not look like us, that we are ensuring that timeouts are done in the OR, that we are, again, advocating as a population. So here in New York City Health and Hospitals, I'm so pleased to share that our data around maternal mortality is actually lower, and we have a higher rate of vaginal deliveries versus C-sections. There are some bad cases, but they are significantly lower nationally than the national average. And we have new innovations like simulation that we're teaching all of our nurses across the system, and we're doing work. We just hired a new nursing simulation instructor for the system. We just hired a new chief women's health services officer by the name of Dr. Wilcox. I mean, she's just phenomenal. But again, to the people who are here, if you're in the academic setting, please make sure the curriculum is talking about diversity and inclusion. Please make sure the curriculum is talking about social determinants of health. For those who are in the different settings I talked about, whether it's nursing homes or hospitals, make sure the nurses are thinking about what happens to their patients, and are we advocating for our Black and brown people, right? And so we at New York City Health and Hospitals, we're doing comprehensive care. We are on a mission to care for the underserved, and we're doing a fantastic job about it. But as we are the largest public health system in the US, we are committed to addressing health inequities. We are committed to serving the underserved, and we're proud about it. I always say it's the best time to be a public health nurse because we are in a public health crisis. And so now, finally, this is the window of opportunity to get people to listen, to get funding, to make sure that NANNA is getting funding to do research within the topics that impact our people. And so, as I mentioned before, think about this, not just in New York City, right? We are the most trusted profession. Now is the time to do something, right? We are the largest segment of healthcare. And I remind everyone that when I walk into a room, when I talk to finance, I'm the largest workforce here and across the world. So you got to listen to us, right? And one of my major goals is to make sure that nurses have a voice in public healthcare, but to make sure nurses understand the power of their voice anywhere. Right? And to maximize our potential both within the profession and outside the profession, right? And to making sure that we are uniquely poised to take into account the distinctive and diverse cultures, right? So I'm from Haiti. My parents are from Haiti. I was born in New York, Nigeria, whether it's Ghana, Uganda, anywhere we are, to make sure that we're making a difference in the care and the lives of our patients that are in our communities, right? And so in summary, I shared a lot, right? But I want to remind you that nurses, we are integral to designing. I am creating new healthcare delivery models. I am redesigning the way that bedside nurses are thinking about their patients, because we got to get them to the next level, right? We are our future, no one else, right? And we are implementing national, and we need to implement national and guess what? International policies, public or private setting, to address the social determinants of health, widespread, to make sure that we're addressing health disparities. Because if we don't do it, guess what? No one will. We have to. So the question is, what should we do next? We have to do something. It starts with conferences like this. And so thank you so much for the invite. I hope I shared something new. I hope I've invigorated you to get involved in your communities, to think about what's happening, within the nursing profession, and how can we use this pandemic as an opportunity for us to do better, for us to make sure we're doing an opportunity to do better within the African community, to make sure that we're doing a better job just within all of the nursing profession, again, nationally or internationally, and to make sure that we can advocate every day in every setting, the boardroom or hospital meetings, or community meetings, community board meetings. And so please, if there's one thing that you take away from this presentation, is that you can make a difference, we can make a difference. And despite how hard the last 2.5 years have been, we can make a difference by coming together. As I wrap up, this is a photo that was shared. And this is just when the Air Force, the Navy, and the Army came, and our nurses took photos, right? So the Department of Defense came, academics came, clinicians came. We are all one, despite where we work. And so if we can come together as one to make a difference in healthcare disparities, it's going to just be phenomenal what we can do for our communities. Thank you so much.